So you could move on now, actually, Joe. Thanks. So 20 minutes. I mean, I can talk about thrombosis prevention all day. I obviously won't. 20 minutes isn't long, but we'll just have a look at sort of some of the recent history of thrombosis prevention and where we're at now, and talk a little bit about some of the contentious areas of thrombosis prevention, and have a look at some national data from the National Thrombosis Survey. So just a brief and not exhaustive timeline of where it all began. I know that some of you are not specialists in thrombosis and might be coming to this from a background of, well, a general medical or general surgical or all sorts of, there's midwives, there's pharmacists, they're great. Where it all started really was in 2005. House of Commons Health Select Committee highlighted that VTE, excuse me, in hospitalised patients was a significant and largely preventable problem. So that was the catalyst for action aimed at reducing the risk of VTE in hospitalised patients throughout, I suppose, the next decade and beyond. If you can move on the slide, please, Joe. Thanks. Keep going. So we'll look at what's new in thrombosis prevention. As I said, the National Thrombosis Survey has been very helpful in giving us a picture of what's happening. We have a network and we chat about some things, but this included sort of non-exemplar centres, just seeing how people are doing really and how people are managing the whole process of risk assessment and providing appropriate prophylaxis. And then what does good practice look like? Well, we've got nice guidance and we've got published evidence and some big gaps in between. So what does it look like where you are? What of your thrombosis committee, if you have one, recommended for patients that fall in between the gaps a little bit, or where the evidence isn't very clear? Okay. So Joe, if you show us the next slide, please. The National Thrombosis Survey, it sounds a bit dry to be talking about a boring report. It's not boring at all. It's very informative when you're in this world. And it gives us a springboard to talk about your experiences as well. So we'll just rattle through it and then we'll have a chance to for a bit more interactive time. So the aim of the survey was to audit hospital-acquired VTE and determine how thromboprophylaxis could be improved. There are lots of themes. It's a chunky report. I'm going to talk about some of the key themes here, which included missed doses, provision of patient information, use of anti-embolism stockings. Okay, interestingly, litigation costs documented in the report, £86 million over 5 years, and increasing in amount every year, not necessarily increasing in financial burden, not necessarily in number, but the payouts are getting bigger. So these are all negligence claims costs related to HAT. Okay, so that is significant. This was the first survey of its kind, Thrombosis UK, in conjunction with the Getting It Right First Time programme you may have heard of. Acronym is GIRET, and it's a terrible word, but yeah, I might accidentally use it a couple of times. So since 2010, since the introduction of mandatory risk assessment, there's been a 20% reduction in post-discharge VTE associated deaths. Isn't that amazing that not as many people are dying as a result of a hospital-acquired clot because of the sort of what's happening at the coalface, what's on the admissions units when you're receiving patients. They're being risk assessed, they're being offered prophylaxis, and brilliant. That is really good. As always, there's more to be done, and so this report helps us understand that. Next slide, please, Joe. Thank you. Yeah, thanks. So the results showed that about 80% of trusts that responded to the survey request were using the National Risk Assessment tool. We're using that, or we're using an adaptation of it. There doesn't seem to be any other risk assessment tool that is fit for the widespread purpose that is. And yes, there are limitations to it, but seemingly majority of sites are using the Department of Health tool. About 90% were routinely identifying and investigating HAT, hospital-associated VTE. Now, again, in your role, you may not be specifically involved in identifying or investigating HAT, but I thought that was quite encouraging. And 88% of patients who were eligible for pharmacological thromboprophylaxis were prescribed it. Again, that's not bad. There's room for improvement, but that's pretty good. Could be better, I guess. 67% of patients received pharmacological prophylaxis within 14 hours of admission. Now, we are struggling on that front. And we'll talk about that in a sec, perhaps. And 8% of patients had doses of pharmacological thromboprophylaxis missed, either due to patient refusal or without clinical reason. So again, it's not terrible, but it's not great, is it? If somebody's prescribed something and it's not given, there's work to be done. We'll move on, Joe, to talk about patient information. Again, we're not great at this locally. 31%, 37% respectively received written and verbal information. A bit better results for the evidence of stockings being fitted and monitored according to NICE. I've just pulled out some data there about the use of stockings in medical patients and or mechanical prophylaxis, not specifically stockings, in medical and obstetric patients. Again, we're routinely putting our obstetric patients in stockings, which we don't need to do. So we've got work to do in that area. And the HAT rate, which it's quite difficult to represent because there are lots of different variables. It's around 2.3 per 1,000 admissions. This is a baseline. It gives us a start. It helps us to know where we benchmark in terms of that number. If we're significantly higher or lower, are we all sort of looking at the same patients? Are we all tolerating the same deviation from care? So what about where you are? And this is where it would be helpful to just pop something in the chat if you're able to. Do you have VTE education induction? So if you're a prescriber, is VTE covered at induction? We've just done some sessions for some of the new FY ones, actually on the whole thrombosis prevention and anticoagulation. Just wondering locally, if you're a junior, just stick in the chat whether you have had some education about VTE. Are you involved in routinely assessing patients for VTE? Again, largely, it's certainly in our place, a prescriber role, but midwives involved in assessing patients for their risk of VTE, and the nurses in our pre-op units do it too. So yeah, let me know if that's you. And I don't want to sound like insulting or patronizing, but are you routinely prescribing thromboprophylaxis when it's indicated? So 88% of patients in the survey were prescribed thromboprophylaxis when it was indicated, but that wasn't 100%. And I wonder what happened to the 12%, or why, what happened between the risk assessment process, which indicated that prophylaxis was necessary and the failure to initiate prophylaxis. Perhaps something changed clinically, but it wasn't documented. So yeah, I think sometimes it gets a lot. You can just get distracted, and oh, such a body needs such a thing, and that's more important, and then it gets over, and then it gets lost. And how are you doing about the 14 hours first dose within 14 hours of admission? Thank you. I'm just reading the chat. Patients are assessed, not always promptly. Agreed. Yeah, same here. They will nearly always have done an assessment within the first 48 hours of admission, but that's not really good enough. No longer have VTE education routinely for nursing induction at Brighton, but the doctors do have on induction. Yeah, okay. So we did quite a lot of VTE induction for our nurses, and then there was a big overhaul and it got ditched. So similar, I think, to you at Brighton, Sally. Surgical ward, we do have VTE induction for all new starters. Brilliant. We've been scoring pretty well across all areas mentioned as we prepare to apply for exemplar status. Brilliant. Well done. Yeah, good. It's amazing what can focus the mind, isn't it? And not even necessarily locally, but or at ward level, but sort of, you know, if there's an agenda from sort of the trust board or medical director, things can start to happen. Okay, as advanced practitioners, no, we don't cover this, but maybe it should be covered when we start NMP. Interesting to know what clinical area you're in, Joe. Again, locally, we've been having a conversation about the importance of where we can mandating education about thrombosis prevention for clinical staff. So we would be keen to support that notion that it's relevant for everybody, really, whatever clinical area you're in. Thrombosis prevention is across the board clinically. VTE prophylaxis is normally prescribed at 10 p.m, so may not be within the 14-hour timescale. Yes, it's the same for us. It's routinely prescribed at 6. And so if a patient's admitted at or clerked at 7:15, then we've got an electronic prescribing system which prompts, do you need to prescribe a stat dose, but it's just not always done. And I think because of that culture of 6 o'clock is anticoag time, 10 p.m, where you work, Chetina, it's quite difficult to change that. And then there's this question about, well, what if I give it at 2 a.m. and it's next due at 6 p.m? Is that enough time? And what if I then need to give a treatment dose? And yeah, there's all sorts of nuances. What if I'm waiting for platelets to come back or renal function? So yeah, doesn't always get given. So VTE lead in elective surgery, we risk assess everyone at POA, pre-op assessment, except patients only having endoscopy. Yes, they are reassessed within 24 hours or at change of condition. All our nurses and healthcare assistants complete a VTE competency. Yeah, great. That's really good, really good. And yeah, brilliant. Really good example of good practice there. All our surgical patients in cardiothoracics are assessed as high risk. We prescribe post-op as long as not bleeding. That can be after 14 hours of admission. I guess if you're making an intervention with a surgical procedure, then it may not always be appropriate to give it within 14 hours of admission. And similarly for arthroplasty, you know, if you expecting to operate on somebody quickly when they're admitted, then you may not want to give prophylaxis. But I suppose about just considering and challenging the culture of, we always give this at 10 p.m. or we always give it at 6. I'll just keep going because the chat is active. Brilliant, thank you. Re-education following a SUI here. It's clear that whilst everyone knows about VTE risk assessment, the lack of knowledge of how to manage patients who cannot have low molecular weight heparin. Lack of thought processes with juniors and nurses continue to omit doses and died of PE. Education to nurses to question omission and for the medics to have more discussion about other forms of TP. Yeah, and we will unpick some of that later on in the talk. Thanks, Sue. A Bolton VTE is a routine part of induction for junior doctors joining the trust. Great, good. I'm working on VTE risk assessment, and hopefully our trust will have mandatory form. Yeah, and that's how we did it. We put it in the clerking booklets because a loose piece of paper just was never completed. So incorporation of the clerking booklets electronically, we're moving towards that now. I don't know whether that will be beneficial to our risk assessment rates or detrimental. It's a bit difficult to know, but I think the culture, I think most doctors expect to do a risk assessment when a patient's admitted, whether that's just because it's been part of the clerking booklet for so long. And I think the culture has changed. When I first started trying to persuade, clinicians that VTE risk assessment was a worthwhile exercise, it was a bit like blank faces. 6 to 8 hours post-op, again, fine, as long as it's being considered. Critical care. Oh, okay. Hi, Joe. You're local. Brilliant. Yeah, and prophylaxis 6 hours post-op. Yes, that's sensible. Well done, Carol. You give a stat dose if after 6 p.m. I'd be interested to know how you challenge the culture of waiting until the next 6 p.m. dose. Okay. A dose required change from EGFR to creatinine clearance. I noticed a delay in prescribing. Yes. So we use EGFR for prophylactic doses, but creatinine clearance for treatment doses, and it does simplify the approach. North Wales thromboprophylaxis nurses provide VTE and prevention training, not mandatory, but everybody gets it on induction. Question from Mary. What is the importance of giving thromboprophylaxis within 14 hours? What is the significance? My understanding is that the 14-hour gateway, if you like, is supported by a requirement for patients to be post-taked within 14 hours or reviewed by a consultant. So that's where the 14-hour window. Emma, thanks for popping back up because you can correct me if I'm wrong. So it wasn't so much of a clinical consequence, although there'll be that as well, but it was the 14 hours was already a target by which patients should be reviewed by a senior doctor, and that fitted quite nicely to put the thrombosis at first dose of thromboprophylaxis within that timescale. Emma's nodding. Do you want to add anything, Emma?
No, absolutely right. It's a little bit arbitrary in that there isn't any specific evidence to suggest that giving it within 14 hours reduces the risk of thrombosis. But like you said, Becs, it's just about prompting, making it work really with the hospital flow and the pathways already in place. So yeah, you're absolutely right.
Thank you. A question about reassessment. So it used to be a nice standard that patients were risk assessed within 24 hours. They now suggest that happens whenever clinical condition changes. So actually locally we adopted that strategy right from the start, really. It didn't seem, for the sake of it, reassessment at 24 hours admission, unless the clinical condition had changed, and in which case a change in clinical condition, whenever it happens, it should prompt reassessment. And I know it happens, but it's rarely documented. So again, if you're involved in assessing patients and for some reason a platelet count drops, whatever happens, they start bleeding, and you do a reassessment, because you will be doing a reassessment because you'll be thinking, all right, they're bleeding. Now I need to think more carefully about whether they get prophylaxis, pharmacological prophylaxis. Please just document it, because that's mega helpful. Even if you just write thrombosis risk outweighed by bleeding risks from now, stop prophylaxis. That's mega helpful. Great, thanks for your contributions. Let's move on to the next slide, Joe, because I think similarly, you may have covered some of this. Do you have a local patient information leaflet? Do you have a trust specific leaflet, or do you use the nice one? Do you use Thrombosis UK? How are you In terms of access, are they readily available on the ward? We know that from our print-on-demand service, the number of patients that comes through the trust doesn't equate to the number of information leaflets that are ordered through print-on-demand. So we've got a discrepancy. That's just a really crude way of identifying that discrepancy. How confident do you feel about giving verbal information to patients about VTE? Somebody asked you, well, patients can come up with all sorts of random questions, can't they, about thrombosis prevention. Why am I taking it? Why does it sting? Why do I need to keep them on, my stockings on all day? Can I take them off to go to bed? How long should I wear them after my operation? All those sorts of things. How confident do you feel about giving information to patients if are responding to questions? And have you been trained to measure and fit anti-embolism stockings appropriately? Again, I used to have a reasonably good grip, pardon the pun, on what was happening locally in our organisation about training for stockings, and then we changed supplier, and this just all feels a little bit sort of far away now from where I want it to be. So it may be that you've recently changed suppliers and you've got this green one and it looks different from the one that you used to use, and oh, how many measurements do I need, and all of that. So again, just pop in the chat if you've got any comment to make on that. And then perhaps the next slide, Joe, please. Are you regularly using anti-embolism stockings in medical or obstetric patients? So there's no evidence that anti-embolism stockings are beneficial in medical patients. But, you know, we see clinicians that somebody with a good going thrombosis risk who can't have pharmacological, can't have heparin, they want to just put stockings on them just in case they're helpful. And I can see why, but no evidence that they're beneficial. And actually, you know, if they're not measured and fitted and changed and all of that properly, then they can do harm actually. So yeah, it's difficult. So thank you, Archer M. We don't have VTE education. We used to have a great rep who came to teaching and gave us loads of info, but since COVID and since she left, we haven't had the same coverage. Yeah, I mean, whatever your opinion on reps, they can be quite helpful in terms of getting into places and delivering updates specific to their product. So COVID has made that more difficult. I think if you're one person or two people trying to cover like different sites and different specialties, somehow the reps just can get there much faster than you. Are you able to explain to patients about the benefits of thromboprophylaxis if they refuse it when they're offered? Again, documenting is mega helpful when it comes to this. So if you offer a low molecular weight heparin injection to a patient and they refuse on many different grounds, are you able to explain why it's important to have it and answer their questions? So we occasionally would use a DOAC in somebody who is needle phobic. We would use fondaparinux if it's appropriate in somebody who had objection to using porcine derived products. So there are other options for patients who, you know, who struggle. And for how long is post-discharge thromboprophylaxis used? Just thinking about a day case at our place where everybody just kept stockings on for 6 weeks post-op. It didn't matter what they had. You know, you could have had a wisdom tooth extraction and you had to wear your stockings for 6 weeks, and challenging that. This is quite tricky. We use Clexane reps. Company provided different forms of patient education in several languages. We're no longer using Clexane. Yeah, and I was on the Apixaban website yesterday looking at different patient information. They've got loads of different languages. Brilliant. It's really helpful. But yeah, when you sort of switch supplier, you're sort of starting all over again. is a colour-coded tape measure that is one measurement around the ankle. They're from Fit Legs. All patients get a one-page leaflet on discharge saying keep mobile, keep hydrated and deep breathe. Yeah, brilliant. It's good. I think if you are confident that that's happening, well done. I mean, the survey seems to suggest that it isn't, and certainly locally, it's better in surgical patients, seems better in obstetric patients, but provision of patient information leaflet is written information. Of course, if you're giving information verbally and not documenting it, then nobody knows that that's being given. Let's move on because I'm conscious of time. So there's a bit of contentious recommendation in the NICE guidance, where NICE recommend a minimum of 7 days for all acutely ill medical patients, and the majority of, and all surgical patients, a minimum of 7. Some they recommend longer than 7 days in some surgical patients. Certainly the exemplar centre leads, when they were questioned about whether they're doing this, said, no, we're not doing this. We have a more targeted approach, which seems reasonable. I don't know many centres that are routinely giving 7 days thromboprophylaxis, including after discharge, to medical patients. If you are, let me know, pop it in the chat. I'm going to talk just, again, I'm conscious of time, and the next talk is about COVID. Just want to talk briefly about VTE prophylaxis in COVID, and then I'll come back to the chat. So we know that COVID-19 produces a hypercoagulable state for patients. There are significantly higher rates of VTE in patients with COVID pneumonia than other types of illness. Advice for intervention is changing frequently. I've not specified because just if you routinely look after COVID patients, you'll know it. If you don't, check, because it will have changed between now and the time you next see a COVID patient. And it's called a rapid guideline for a reason. It just keeps changing. So do check locally as well what you may have agreed something. Again, these nuances and these gaps in guidance. So just continuing, Joe, with the slides. Risk assess, offer standard prophylaxis, standard prophylactic dose where that has in the past been an intermediate dose or a treatment dose. Where NICE now recommends standard prophylactic dose low molecular weight heparin, and continue for a minimum of 7 days. Now we are actually giving a minimum of 7 days to COVID patients, including after discharge. We have picked our NICE guidance that we wish to, or that that we're deciding to follow. And COVID in pregnancy, I don't know if Susie will speak more to this in a little while, but again, risk assess, offer prophylaxis. Actually, even if their patients are at home and isolating, because self-isolating people tend not to mobilize as much as people who are free to leave their home, and a minimum of 7 days at discharge, extended to 6 weeks if ongoing morbidity. So again, in line with sort of other RCOG guidance. And then finally, take-home messages from today. It's been a bit of a whistle stop, hasn't it? But take-home messages: document any decision that you make, any action that you take that is not clear, I suppose, and is perhaps different from what might be expected, and encourage mobilizing, hydration, and information provision.